Our next speaker is Professor Djimde, who leads a research group at the University of Science, Techniques and Technologies in Bamako. That is working to understand how genome variation in the Plasmodium falciparum parasite, its human host, and Anopheles gambiae can contribute to mechanisms of malaria disease spread.
Good afternoon, ladies and gentlemen. Probably a wrong title there. I'm going to be talking about novel strategies for malaria elimination. As you all know, the recent concern has been the fact that the downward trend of malaria mortality and morbidity have stalled in the last few years, and in actually some areas they're starting to be a reversal of the gains that were observed. This graph shows this downward trend that in the last 2 years is now stalling, and in some places is even going up. And the WHO recent report indicate that the biggest burden of this problem of persistence of malaria is in 10 African countries, 10 sub-Saharan African countries, and India. As you can see, we have Nigeria at the top of the list, DRC, and a number of countries, including Mali, Burkina Faso, that still are carrying the biggest burden of malaria. So 10 in Africa plus 1 in India. This is the list, a list that WHO has, a list that each country is trying to get its name off as fast as possible. This illustrates the number of cases. Again, in the 10 African countries, the 10 highest burden African countries, and as you can see, there is actually an upward trend of the prevalence of cases of malaria. So again, as in the eradication attempt that was made in the 50s, the current elimination and eradication program is having problems in sub-Saharan Africa, and as long as we don't fully address this issue of high burden in sub-Saharan Africa, the goals of eliminating and eradicating malaria is not going to be reached. So what are the tools that are currently being used to control and eliminate? And just to remind, we have case management that include prompt diagnosis, artemisinin-based combination therapies, artesunate for the severe cases, and where artesunate is not available, we still use quinine, and all of this is home-based management is being promoted to accelerate. And we have the prevention. We have seasonal malaria chemo prevention in eligible areas, IPTP in pregnancy and IPTI in infancy, and various vector control measures that Wanji is going to be talking about. So to reach the malaria elimination, we do need to accelerate control in these high burden African countries. And this will require not only scaling up the measures that we have, but making sure that no one is left behind, which is making sure that all the interventions actually reach all the areas where malaria is a problem. And this calls for improved health system novel strategies that can bring the interventions to the patient that need it. I think Prof. Guy is going to say more on that. So in addition to that, we need to be creative on how we can maximize the impact of the existing tools to get us where we want to be. So there is a number of strategies that are in sometimes in research, in more of in research of implementation research field that are trying to assess new ways of combining the existing tools so that we can accelerate the decrease of the cases of malaria. We have the RTSS, the first vaccine that is in pilot implementation, and various additions of tools that I will go through in the next few slides. So RTSS is our first malaria vaccine that is in pilot implementation in Ghana, in Malawi, and in Kenya. It's not a perfect tool, but we think it is a very good start. It at least demonstrates that it's probably possible to have a malaria vaccine. And if the pilot implementation yields positive results, we think that this could be an important addition to the existing tools to combat the disease. Our colleagues we have tried to see how we can improve the SMC strategy, seasonal malaria chemo prevention strategy, by a number of additions to it. One of which is adding an antibiotic, azithromycin, that was shown to decrease mortality on its own in previous studies. So the question was to see whether adding azithromycin to SMC, what the impact of that would be. So a large study was conducted in Mali and in Burkina Faso, where a double-blind randomized placebo-controlled trial was conducted in a better part of in nearly 20,000 children in 3 malaria transmission seasons, with the primary outcome of looking at all-cause hospital admission and death. So the study is already published. The primary endpoint did not yield positive results, as there was no statistical difference between the SMC plus azithromycin versus the SMC plus placebo. However, when you look at the impact on other morbidity measures, including looking at malaria, you can see that there was a downward trend with the addition of azithromycin, but that it didn't reach statistical significance. Same thing with acute lower respiratory infections, that there was also a decrease that did not reach statistical significance. But there was a significant decrease on non-malaria febrile cases, as well as on acute gastroenteritis. So overall, the addition of azithromycin did decrease the overall morbidity that these children suffered. This is another study that is ongoing, trying to add the new vaccine on top of the seasonal malaria chemo prevention. So the question is, would this new vaccine provide any added benefit on top of the SMC that is going on? This is a study that is going on, again, a double-blind randomized controlled trial with 3 arms in Burkina Faso and in Mali, with about 6,000 individual children involved, with the primary endpoint being looking at incidence of clinical malaria. It's a blinded study. The study will be unblinded next year. And hopefully by next meeting we can have the results of this study. This is another study adding a primakin dose, low dose, to SMC in the attempt to see whether we can decrease the infectiousness of mosquitoes that are being circulating in the community. So this was so as the results, as you can see, this is looking at infectiousness to mosquitoes at day 2 and day 7. This is a baseline with the SMC drug, SP plus AQ, and here adding a low dose of primakin. As you can see, there is a drastic reduction both at day 2 and day 7 in the infectiousness of mosquitoes. So adding primakin would lead to decrease infection transmission in the area. So in addition to those attempts, we need to sustain the gain. We need to try to deter ACT resistance. And there again, a number of attempts are being made. Multiple first-line treatment is being tested in a number of places, and a few models are there to see how this simultaneous distribution of different first line can help in decreasing the malaria situation. Other attempts are using successively different ACTs, one ACT for 1 or 2 years, and then another ACT for 2 more years, and then changing to a third ACT for another years. These are also things that are being tested. And a number of studies are testing triple ACT, which is adding one additional partner drug to an existing ACT, artemether lumefantrine plus amodiaquine, artesunate piperacin plus mefloquine, or artemether lumefantrine plus atovaquone proguanil are all being tested both in Asia as well as in Africa. So there are attempts of combined strategies as well, where you can use SMC plus IPTP. So when doing a door-to-door SMC screening for pregnant women and providing them with SP in a way of trying to increase the penetrance of SP, which has been lagging behind. Another strategy, the SMC plus targeted bottleneck strategy, or various iteration of MDAs are also being tested. So would this be enough for eradication? Probably not. For eradication, we'll need novel drugs, next generation vaccines, next generation diagnostics. We will need to target the non-falciparum malaria as well, Vivax, malaria ovale, and we need to increase our understanding by looking at the parasite genetics and using those novel tools in the implementation strategies that we use. None of this will be possible without sustained funding, and to sustain this funding, we do need advocacy, both at the international level, but also for us Africans to intensify advocacy at the local level to increase our government's local funding for these initiatives. In conclusion, in Africa, we say that it takes a village to raise a child. It will take the whole world to eradicate malaria. And we Africans will need to be key drivers in this fight because we are where the disease burden is highest. I will finish by thanking ASTMH again for this opportunity, the MIM Society, and my colleagues who provided some of the slides that I presented here. Thanks for your attention.